Okay, thank you very much. And with only a half an hour, what I really thought we could do is try to focus on mostly leiomyosarcomas and mostly the new trials, because there's a number of new drugs that are out there. And I thought it's important that we review some of the trials. There's been quite a bit that's come out in the last year to two, and I think you should be familiar with that. So we'll go ahead and get started with that. Disclosures you've seen 3 times already today, so let me get started. So I think one of the important things to understand is that sarcomas represent a very diverse collection of tumors, and you have literally, if you're a splitter, you could go on to about 30 different sarcomas. And I think, certainly I think this pie chart shows nicely that leiomyosarcomas and liposarcomas make up the majority. But you have a high percentage of GIST tumors and bone sarcomas and other soft tissue sarcomas that occur as well that are unclassified, or angiosarcomas, myxofibromasarcomas, and synovial, and it goes on and on. So the important thing is that there's a good pathology review. Your pathologist is very important in this area in terms of determining that. So you see here the diversity in the histology, and there's, as we get more into targeted therapies and biologics, again the same theme. It's important to understand what histology you're dealing with and what the implications are in terms of the sarcoma. So in terms of incidence and outcome survival, I think most people are pretty familiar with the fact that they represent a small percentage of GYN malignancies. I was just joking with Eric. I said if a projector went out, I'd be in trouble on this talk. An ovarian talk, I could literally stand up with a piece of chalk and go over all the main studies and numbers from memory, because I've given those talks so often. So it's always a little more of a challenge to give an overview of sarcomas that do make up less than 1% of our collective experience in terms of the number of tumors that we see. They represent only 3% of all uterine cancers. So again, a very small percentage. You see less than 2 per 100,000. But they tend to be very aggressive. Stage is still very important in terms of predicting how these patients are going to do. But it's frustrating, right? Because even uterine confined disease can do poorly, and really being fairly thorough in terms of looking for disease outside the uterus, they still don't do very well. So the chance for occult escape of cells is very high, and it presents a very poor outcome. Adjuvant treatment for early stage is unclear. We thought we kind of had that figured out, and it really doesn't appear that we do. We know that radiation may help, again, with somewhat of pelvic control, but that's all we get out of it, and in fact not even to the same degree that we see with endometrial cancer. So the enthusiasm for radiation has waned as of recently. Major sites of failure include pretty much everywhere in the body, pelvis, the upper abdomen, and the lung area. Recurrence rate, again, is dependent upon homologous versus heterologous elements, depending on if it's a carcinosarcoma, and I'll talk a little more about breaking all these things down here. So Eric showed you the mortality by histology, and certainly you can see the sarcomas do very, very poorly as far as outcomes. And the way we've classified them largely is the good, the bad, and the ugly. And so the endometrial stromal sarcomas and adenosarcomas tend to behave very well. The not so well, the uterine leiomyosarcomas and carcinosarcomas, and then the ugly, meaning that they just generally don't do very well at all, even with aggressive treatment, or the undifferentiated and the adenosarcomas with sarcomatous overgrowth. So the endometrial stromal sarcomas, I'm not going to spend very much time on them. They tend to be low grade with less in the way of atypia, less than 10 mitoses per 10 high-powered fields. They are less likely to metastasize or recur if they're low grade. The high grade ones are much more aggressive. They do metastasize more quickly. The good news is we have new targeted agents and hormonal agents and so forth that are available for these. Carcinosarcomas, Certainly, we tend to think of these more as carcinomas, frankly, in terms of how they behave and so forth, and they're treated as aggressive endometrial adenocarcinomas rather than as sarcomas. So I'm sort of taking these, off-lifting them from the talk. So you see, IFOS and cisplatin and carbo and paclitaxel and so forth that's used for the carcinosarcomas, which then brings us to the Leiomyosarcomas. They represent about a third of the sarcomas. The Stanford criteria are still widely utilized, including the number of mitotic figures, the presence of nuclear atypia, as well as the presence of coagulative tumor cell necrosis, are all important in terms of prognostic factors. We also think size and the mitotic index alone are important. Again, even confined to the uterus, survival for 5 years is about 50%. So we're not doing very well. Adjuvant radiation seems to have no impact on recurrence rate or survival. Median overall survival with advanced or recurrent leiomyosarcoma on average is less than 10 months. So not very good. These are, how do we make the diagnosis, and how do we make the diagnosis preoperatively? It's very difficult. Even in the face of what we think is a rapidly expanding uterine tumor, still the majority of them are in fact leiomyomas and not sarcomas, and so it makes it very difficult. Now I could give an hour's talk just on the whole morcellation issue that's come out of this, and I don't know if many of you are familiar, but it's an unfortunate case in Boston with a couple, both of whom were physicians. He was a cardiothoracic surgeon, and he has been very vocal, very public about the whole morcellation issue. And it's extremely sad. It really is. It's his wife was Dr. Amy Reed, who was an anesthesiologist, and she ended up dying in this case. And they've been very public in, obviously, the disclosure of their medical information, but also they've been very critical of organizations. They've been very critical of gynecologists and gynecologic oncologists and so forth. And, some of the things he's said have been very helpful, and many of them have been very unprofessional, frankly. As I said, I could spend an hour going through some of his quotes and so forth that if we applied the same standards to what goes on in cardiothoracic surgery, we could make him not look very good either. And I have a slide that actually does that. So we'll leave it at that. So what's the role of doing lymph nodes and removing the ovaries? Well, in terms of, what we see for involvement, it's not that high. So it's about 3% are positive from the ovaries. And lymph nodes overall, you have cases with none, and then you have cases with 6 or 7%. If you balance the numbers, it's probably 5-6% that are positive lymph nodes at the highest. And so we say, well, you don't need to ever remove lymph nodes with sarcomas. Anyone remove lymph nodes with leiomyosarcomas? Anybody? Okay. Well, it's interesting, right? So 5-6%, we say, it's not very high. And yet, what do we do for cervical cancer? It goes from less than 1% to 3 or 4%. We say, you must do lymph nodes. It has therapeutic benefit, et cetera, et cetera. So it's interesting why we do what we do sometimes and what the cutoffs are. Prognostic factors and survival, and so there's a lot of different things. I've covered those. You can see the different survival curves. I'm not going to spend a lot of time on what's, I think, old information. Let's get to how we treat these and some of the thoughts that are out there in terms of the newer treatments and how we incorporate those. So in terms of options, lots of options out there. You have gem-doce, you have the trial looking at Bev, you have a trial looking at up against Doxorubicin, you have, should we add in some of these new agents such as Pazopanib, Trabectedin, Eribulin, and we'll talk a little about Olera as well, the PDGF agent. And is there a role for immunotherapy? So lots to talk about. So this is the backbone of the idea that gem-doce would be effective in this, and this was a study that was a second-line phase 2. And I don't think a lot of people realize this was a 48-patient phase 2 trial that generated a world standard of care. Very interesting. You usually don't see that. So, many of us could do a 48-patient trial in about a year and a half, and here you are getting, what many would figure would be an entire career of work to get to that level to generate a standard of care that's global. Nonetheless, it's based on a response rate of 27%, so pretty good. And these data really serve as the benchmark for comparison of any new agents in terms of expectations for response rate and PFS that was seen here. So high standard stable disease rate as well. And in this second-line therapy, all these patients had been exposed to Doxorubicin prior. So I think it was virtually all of them. So similar benefit was seen if you move this to frontline. So this was a GOG study. Again, looking at a low number of patients, 39 patients. Response rate here, 36%. Similar benefit as what we saw, but with a higher response rate. So your response rate went from 27% to 36%. Clinical benefit rate, again, being fairly high. Marty Hensley from Memorial was the principal investigator on both of these trials. So this was an EROTC retrospective review of multiple clinical trials in soft tissue sarcoma. And in patients with prior therapy, chemo agents considered to be active were those associated with progression-free survival rates, 39% at 12 weeks and 14% at 24 weeks. So it gives you an idea. So by these bars, gem-doce would be considered highly active, and so to set the stage for this. So that was taken up by NCCN and most other organizations. So hoping to build on the success of fixed dose rate gem and docetaxel, and given the modest success of Bev for treatment of other solid tumors in combo with chemo, GOG 250 was launched, randomizing patients to gemcitabine docetaxel with Bev or against placebo. And while it's clear that Bev did not improve response rate, it was still gratifying to see that the overall response with gem-docetaxel in this large phase 3 trial were very much similar to what was seen in phase 2 trials. So while we really never did a phase 3 trial testing gem-docetaxel, you could really look at the control arm of GOG 250, a trial that most of us have forgotten about because it was a negative trial, to at least give some validity to the otherwise small phase 2 data. There was no improvement in PFS with the addition of Bev, and the median was about 5 months. And so with that, then really no role for Bev currently. So this was an interesting trial here, and this is the GeDDIS trial. Phase 3 trial looking at gem-docetaxel versus Doxorubicin as frontline treatment. And this just came out in Lancet Oncology this past year, the final results of this. So again, this is first frontline, looking at Doxorubicin versus pretty standard doses of gem and docetaxel. Primary endpoint was PFS at 24 weeks. So a little bit of an odd primary endpoint landmark analysis, and they looked at other things as well, stratifying for histologic subtype, age. So these were the toxicities. As you can see, fairly similar. You had more febrile neutropenia with the Doxorubicin group, a little more neutropenia. You had a little more fatigue with the gem-docetaxel group. More mucositis with Doxorubicin. Of course, you have the long-term treatment effects with Doxorubicin, which may or may not be of any interest in someone, unfortunately, with Leiomyosarcoma. And then this is looking at the PFS and the OS data here. So if we look at the primary endpoint of PFS at 24 weeks, you see that they were exactly the same. No differences in the medians, no differences in the outcomes there. So those curves were virtually on top of one another. And so then if you look at this and break it down by a number of other things, you see the quality of life response rate was about 51%, but there was really no difference in the quality of life scores between the two. So if anything, the gem-doce was as active in terms of RECIST response. And so it was interesting because the authors concluded in this Lancet Oncology paper, which should have been heavily peer-reviewed, that doxorubicin should remain the standard frontline treatment for patients with advanced soft tissue sarcoma, and that gem-doce is not recommended as routine. And it generated a whole flurry of editorials and so forth, and talk within sarcoma experts, so including Marty Hensley and others who are saying, "Are you kidding me? I would have said the new standard is gem-doce based on these results." So it's, again, all on how you interpret the data. So experts all looking at the same phase 3 data results, coming up with very different interpretations. So I thought that was very interesting. That's why I really wanted to make this one of the focal points of the discussion this afternoon, to see how you've interpreted this data, because it certainly, I think, has major implications. So same PFS, same OS, maybe slightly better toxicity profile for gem-doce. Certainly something to think about. Next is the phase 3 palette study. So this was a study that really looked at turning away from bevacizumab to other antivascular agents. So it evaluated the oral multikinase inhibitor Pazopanib in any histology except GIST tumors and liposarcomas were excluded, versus placebo, and this was a large phase 3 trial with 2-to-1 randomization for Pazopanib. I don't know if any of you have ever used Pazopanib. I've used it when I was in New York. We were part of the big Pazopanib Ovarian phase 3 trial. It's a fairly toxic agent, despite being oral. It causes a lot of side effects that are important and clinically relevant. So this is the phase 3 versus placebo, and it's always good to go up against placebo. I think that I showed you some slides in the ovarian talk at lunch that the placebo won, or the treatment won over placebo by a large amount. So if you're designing a study and you can get away with it, it's always good to go up against a non-active agent like placebo. So here with the vascular agent being compared to placebo, no chemotherapy, there's a PFS advantage for Pazopanib. But although note that the PFS was only 4.6 months in the winning arm. So keep that in mind. There was no overall survival advantage compared with placebo, which is interesting. So if you can't beat placebo in survival, that's not a good thing, but nonetheless, it did lead to approval. The FDA approval for Pazopanib for soft tissue sarcomas, exclusive of the GIST tumors and the L-sarcomas that were excluded from this. So, really, in terms of talking to patients about this, I am biased by my toxicity experience with Pazopanib. The fact that the response rates were very, very low. If you look here, in terms of response rate, you had a 4% response rate with Pazopanib. And I don't know about you, but I can usually see a 4% response rate with pretty much anything. So it's certainly, that should be almost a negative confidence interval there. And then the PFS is modest at best. So in terms of counseling, yes, it's a positive phase 3 trial, but the clinical impact for me is one of not great enthusiasm. So it's something that I keep as an option for our patients with Leiomyosarcoma, but it's not towards the top of the list. And I'll sort of show you how I sort of go about it. It was FDA approved, though, as we noted. Turning on to some of the newer agents as well, Trabectedin came onto the sarcoma scene in the early 2000s. It's best considered as a cytotoxin. It's derived from a sea squirt. It's a DNA major groove binder, or minor groove binder, major groove bender is the way it works. It has a number of other activities in terms of beyond just distorting DNA. It has an immune effect, changes the microenvironment. It has effects on RNA polymerase, and the bottom line is no one knows exactly how it works because it has so many different effects on the cell. So this particular trial looked at randomizing Trabectedin to Dacarbazine in L-Sarcomas. And by L-Sarcomas, we're talking about liposarcomas and Leiomyosarcomas as a group. So now we're grouping two of the most common sarcoma groups. So we're getting up to approximately 35 to 40% of all sarcomas that would be included in this cohort. So if we look here, you're taking Trabectedin against the Dacarbazine. Again, primary endpoint here was overall survival. These patients were all pre-treated, and it was required that they were previously treated with an anthracycline and ifosfamide containing regimen, or an anthracycline containing regimen alone, plus one additional chemo agent. So these are pretty heavily pre-treated patients. You can see in terms of toxicity, most of it's laboratory, but it favored the Dacarbazine in that respect. The Trabectedin, we've known through our ovarian program, OVA 301, and some others, that we see significant effects on liver in terms of AST, ALT. No Hayes laws in terms of liver failure that were invoked in this study or in the 301 study. So lots of laboratory abnormalities without a lot of clinical relevance, but they should be pointed out. So number of grade 3, grade 4 toxicities that occur, neutropenia led to febrile neutropenia in 5% of the patients on Trabectedin versus 2% on Dacarbazine. So this is the PFS. PFS was the key secondary endpoint, showed a statistically significant difference of 4 months, 1.5 months, 4 months versus 1.5. So favoring the Trabectedin in the whole population, and even slightly greater in the uterine Leiomyosarcoma group. And you'll recall that this PFS in absolute numbers, and the difference is nearly identical to the PFS in Pazopanib. So it gives you some idea that even these new agents are really not moving the needle as much as you'd like. Trabectedin was FDA approved for L-Sarcoma and lipo and leiomyo after anthracycline failures in 2015. So another phase 3 trial that we should address. So lots of phase 3 trials in sarcoma, which is interesting because up till now, I gave a pretty comprehensive talk in Chile, probably 3-4 years ago. And I was looking at all my slides then, and I had all these tables of phase 2 trials, and I've kicked them all out because now we have these interesting phase 3 trials to talk about. It was interesting because we've really moved to sort of a different strategy in drug development in this area. So this is another phase 3, as I said, and nearly simultaneously done with the last one. So Eribulin is another cytotoxic, probably fitting best in an antitubulin family, was studied in phase 3. And also for the L-Sarcomas, also with the Dacarbazine as the active comparator. In this case, the randomization was 1-to-1. The primary endpoint, again, was overall survival. They looked at PFS as well. And you can see here the PFSs were not very good. So 2.6 months in both arms. Overall survival, 13.5 versus 11.5. There's a 2-month overall survival advantage for Eribulin over Dacarbazine. Similarly, there's no difference in objective response rate, with, again, a very low objective response rate, 4% versus 5%. So these are agents that have made it all the way to phase 3, and you're seeing response rates of 4 and 5%. Think of the millions and tens of millions of dollars that's been spent on these trials. Again, overall survival, this is very much like the Trabectedin versus Dacarbazine phase 3. There's a pre-planned subset analysis in here. There was no OS improvement in Leiomyosarcoma. All the benefit was seen in liposarcoma. So FDA approved this only for liposarcoma. So it's not available. NCCN included it for leiomyosarcoma, but it's probably an error if you go back and look at this data critically. So Evofosfamide, people are constantly looking for a better ifosfamide due to the toxicity and the difficulty of giving it. It's a hypoxia-activated prodrug of ifosfamide, and it was given in combination with Doxorubicin versus Doxorubicin alone. And this again is in first-line treatment for soft tissue sarcoma. Study was completely negative. The Evofosfamide was more toxic and no better than single-agent Doxorubicin. So, again, interesting data. This just came out in Lancet Oncology this past year as well. So these are high-impact journals publishing all this flood of sarcoma data that has just come out in the last year. This is the PICASSO study. This is another IFOS better study, if you will. This is looking at palifosfamide plus Doxorubicin. And again, this is a metabolite of Doxorubicin that avoids a lot of the downstream toxic metabolites that you would see. So the thought process is that you would have a much better toxicity profile and perhaps be able to push the dose of this over ifosfamide itself. Nonetheless, you see that overall survival was not improved. PFS was slightly improved. No big differences in anything else, and if anything, it was more toxic. So higher response rate, no improvement in PFS OS. So again, Doxorubicin wins. So this is a phase 3 trial of a Doxorubicin versus investigator's choice in relapse, and again, a prodrug that binds to albumin, localizes to the tumor. In an acidic tumor microenvironment, the Doxorubicin is supposed to be released. This is a randomized trial again, so this is built off a randomized phase 2, suggesting there was some superiority for the Aldox. And this was presented last year at ASCO. And you can see here that in terms of the L-Sarcomas, you see survival 5.3 versus 3 was favoring the Doxorubicin over investigator's choice. Response rate was superior and significantly higher for L-Sarcomas with more toxicity that was seen as well. So this could be something that works out to be a Doxorubicin alternative, so keep your eye on this all-Doxorubicin. And as I said, this data just came out this past year. It'll be interesting to see if we can ameliorate any of those toxicities. It's pending for FDA. There's a Spanish randomized 2 study with Trabectedin and Doxorubicin, and I think I'll skip this data just in the interest of time here. So another strategy is to look at Doxorubicin plus olaratumab. So we've seen a number of combinations. The Olara is a monoclonal antibody against PDGFR, so platelet-derived growth factor alpha, and it has looked fairly promising. If we look here at the toxicity profile, it's obviously more toxic in terms of neutropenia and fatigue. But in terms of outcomes, there was a numerical increase in PFS of about 2 months. It did not achieve statistical significance. So there's still quite a bit of interest in doing this, but based largely off the fact that there was an improvement in OS that you can see here. So you're looking at 26.5 versus 14.7 months. And so this different than the randomized phase 2 trial, which did not show a difference in OS and had shown some difference in PFS. So a little hard to know what to do with these numbers. The phase 3 is done, and the FDA actually approved it in use with Doxorubicin this past year. So a lot of activity with Trabectedin coming online, Pazopanib coming online, L-sarcoma coming online, Eribulin coming online, all in the last 2 years. So quite a few changes. Will there be targeted therapies for uterine Leiomyosarcoma? I think I'm backing up on my time here. So short answer is that we have not come upon any single mutations that appear to be driver that are great candidates for targeted therapies. Immunotherapy may be an option. Eric talked about the role of immunotherapy in GYN malignancies as a whole. This is looking at in sarcomas. There's phase 2 Nevo data out there, not very exciting. This is what we know so far. Pembro, not very exciting. In Leiomyosarcoma, 0 of 10 objective responses. What about if you do combination? Still doesn't look very good. Here's this Pembro with cyclophosphamide, 0% response rate. But this looks a little more promising, and that was Nevo plus Ipi. So this is a randomized phase 2 that was presented at ASCO this past year, and the Nevo-Ipi arm was followed by Nevo thereafter to progression. So if you look at the single arm there on the panel on the left in the orange, you see the Nevo, and the waterfall plot's not very impressive, but it does become more impressive when you add the Ipi in. So the overall response rates are very modest, certainly with single agent Nevo, although Pazo again and some others are 4%. Trab and Dacarbazine have response rates of about 10%. So, by the way, Trabectedin was about 10% on that study, to give you a comparison. But I think that there's some promise here based on the early signals, but again, small numbers, and we have to wait and see. These are the PFS rates that are modest at best, and even at the upper limits of the range, they're fairly short. So even if you look, where they stand, 2.1 versus 4.4 months, nothing that is earth-shattering here. As we move on. So just wanted to wrap up with what I've taken as the approaches. This is sort of my opinion and based on a couple of other thought leaders as well, as to what people are thinking. So most people are doing Doxorubicin with L-sarcoma or one of the other agents that I have paired there. G1 oncologists usually do Gem-doce first, followed by Doxorubicin, and now in the U.S. usually L-sarcoma. But you could do Doxorubicin alone, or you could do Doxorubicin with Evofosfamide as the next step. And then that sort of leaves, in the GYN onc world, Trabectedin or Pazopanib is next up. Or some of the other drugs that you hadn't used above. If you're down to Dacarbazine and Eribulin, you're probably stretching if it's a Leiomyosarcoma. So it's just sort of some notes as to how you order these drugs. So new staging systems, not all that new anymore since 2009. Endometrial stromal sarcoma. We do have active targeted therapies that are available for that. And with uterine Leiomyosarcoma, the risk for death remains very high. It's exciting to see that pharmaceutical companies are investing in trying to do good work in this area in terms of clinical benefit, but I don't know if we've really realized a lot of gain in terms of PFS or OS based on the data I've shown you. But it does give us more approved options, which is good. We used to run out of options very, very quickly. The bad news about many of our sarcoma patients is they don't get much beyond third line anyway. They deteriorate in terms of function fairly quickly, and that becomes a problem. And we talked about the role of radiation. So thank you very much, and again, thank you so much for having me in Saudi. Thank you.